Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We'll be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Marie Mitrani. Dr. Mitrani is the Chief Science Officer and co-founder of Organocell Regenerative Medicine. For the past 13 years, Dr. Mitrani has led Organocell in developing innovative treatments to various health conditions. She was most recently recognized as one of the top 100 healthcare leaders by IFAH for her work spearheading COVID-19 therapeutics. Over the past few years, Dr. Mitrani has built a team of forward-thinking scientists and researchers and has received several FDA approvals to conduct clinical trials. These include COVID-19 acute and long hauler sequelae, chronic obstructive pulmonary disease, and knee osteoarthritis. Dr. Mitrani started her work in her native country, Ecuador, where she co-founded the American Cellular and Anti-Aging Center in Quito, one of the first autologous stem cell centers in South America, and was instrumental in opening additional stem cells clinics in Guatemala, Trinidad and Tobago, and Jamaica. Her background in international aid to underprivileged and underserved people granted her the Humanitarian Award by the Ecuadorian Congress in 2016. I would now like to request Dr. Mitrani to start today's session. Thank you.
Thank you so much for your introduction, and thank you everybody for deciding to join me in this beautiful Sunday morning, afternoon, whatever you're joining from. I'm gonna share my screen and we're gonna go from there. I love to make my presentations interactive, so please, if you have any questions, save them for the end. I think that's what we're going to be following. Once again, my name is Dr. Marie Mitrani. I'm a physician scientist. I'm an MD. I have a PhD. And right now, I'm the Chief Science Officer of Organocell. So I'm going to take you through a little bit of my journey. My name is Maria Inés, and I go for Mari because it's easier to pronounce, and I hate when people chop my name. So that's why throughout all of the platforms, I'm recognized as Dr. Maria Mitrani. As I mentioned, I am an MD. I am from Quito, Ecuador, South America, and graduated at University of San Francisco. Recently, 2 years ago, I got my plant-based nutrition certification from Cornell, as nutrition is one of the biggest things we can do for ourselves and our patients. I think it's very important for everybody that's in the healthcare community to learn a little bit more about plant-based nutrition. I have my PhD in neural therapy, that is understanding the sympathetic and parasympathetic nervous system. I also have a doctorate in acupuncture, or OMD, and I've done a lot of missionary medical work. Very, very proud about that. Currently, there's a lot of certifications and Congress that I attend specifically for the projects that I do, human subject research and clinical trials and investigation with FDA. So from the past to the present, we got introduced into stem cells from physician friends that were doing autologous stem cells for 25 years and presented the opportunity to be able to carry their protocols in Ecuador. We were not only astonished or fascinated, but the results that we encounter with this type of therapy were mind-blowing. So for us, it became our mission to be able to understand stem cells, understand what is the diversity of stem cells, and how to better educate and eventually go to market with a product, right? And this has been over 15 years that we've been working on this project, and finally the fruits of really hard work and tenacity are finally taking over. So we in Ecuador, we got to see many unbelievable patients. Some of Hollywood came down. I have an example of Danny Glover here, and recently one of our team members, our physicians, also many physicians were able to help other recognized stars. So as I mentioned, I am currently who leads the science department in this company. So Organocell is a publicly traded biopharmaceutical company. So we create pharmaceutical drugs, but biologic, right? And we're committed to the research, development, and manufacture of new biologic medicine with a focus on current and potential regenerative therapeutics. So there's many other companies creating biologics that are focusing in other areas. We are really looking to help on those that have a potential to regenerate, right? Or a potential with regenerative therapeutic. We're located in the University of Miami Life Science and Technology Park under the CIC management, and we're registered with FDA as a human cell and tissue establishment. So what is regenerative medicine? Before, regenerative medicine really did not exist. And I learned as we kept going, because it has really bloomed this in these last 15 years that we have been practicing. Now you can actually go and specialize in this branch of medicine. So this is the branch of medicine that specializes in replacing, engineering, and regenerating human cells, tissues, or organs. But most of all, it optimizes the human's body natural ability to heal itself. And I think this is where my passion goes. Since a very young age, I come from a family of doctors. My dad is a doctor. My mom always run the clinic, and we kind of grew up in this scenario of being with patients, and they were specialized and focused on always treating those conditions that were sent to die, or there were no other options. And I always saw the tenacity that my parents had on how they treated and focused in preventative and regenerative medicine that led me to where I am. I took it one step forward and really got into this field. So to make it simple, I like to divide the world of stem cells into two, in the autologous and the allogeneic. So even though they're a little complicated words, just follow along because they're not too difficult. Autologous means your own, from the patient's own body. So we collect it from you, and after isolation, we put it back on you. And this is what led us into stem cells. We're only bone marrow derived or blood derived autologous stem cells. And allogeneic means that it comes from a donor and it goes to another human. So it is not from the same patient, but it is from another human going into another human. And this is pretty much the journey that we have gone through. I'll talk about it a little bit more. So autologous therapies, they can be cellular or tissue-based therapies, and they come from the fat or the adipose tissue, also called the derivostromal vascular fraction. As I mentioned, the bone marrow, there's bone marrow, there's the iliac crest is where usually bone marrow samples are taken, or peripheral blood-derived therapies like PRP. Maybe some of you have heard about PRP. Very common in the orthopedic world now. And allogeneic, as I mentioned, is from a donor. And the ones that I want to focus in the allogeneic is the placental or the perinatal derived tissues. So perinatal derived is the tissue, or placental based is the tissue that's between the mom and the baby, and that usually is considered a medical waste. So it goes in the garbage, it gets discarded. But in the last years, the whole scientific and medical community has learned the power of these tissues of containing cells that are either stem cells or other regenerative cells that are really, really powerful. So that could be the amniotic membrane, the amniotic fluid, the chorionic membrane, the cord blood, the cord itself, the Wharton jelly, and it avoids all ethical and moral concerns. And I want to emphasize it here because usually when you talk about utilizing allogeneic from perinatal derived from it usually people usually think it's aborted fetuses or it's illegal. So it's not. When you are following all rules and regulation, mom and baby are safe, and they're only collected from C-section, and we will go through that. So we, every donor, as I was saying, has to go through very, very rigorous screening, following all FDA guidelines. And so the donor, the mom, when ready for a planned C-section, she has to send the form, and there has to be a medical and physical checkup, a complete medical and social history, and then you do all the viral panel that has to be screen the mom to know that she's not actively with a viral infection, right? And we also, in Organocell, we go one step forward. We have an IRB approved protocol that qualifies all of our donors. So we are taking all precautions to know that this is an eligible donor that can actually donate this tissue. So after many years, as I mentioned, we were working just with autologous, meaning the patient's own body. We understood how powerful it was. But the problem was that there was never a consistency, because every person goes through life with the environment, their illnesses, the medication they take. It's super different. So makes a product at the end of the day not consistent. And we were always looking for a consistent product that we can mass produce so we can get to the masses and help with either pain, which was our focus in osteoarthritis of the knee. And further down the line on our research, we went into lung injury. And so at the end of the day, we ended up with this product. As I say, I think it has taken us this 15 years. It's called Zofin. And we transitioned from actually working with live cells to now it's an acellular product. Acellular means no cells. But I'm going to go down through what is in this product if there's no cells. We manufacture all of our products under CGMP compliant conditions. And okay, so what is in this product? This product contains proteins, exosomes, and hyaluronic acid, or the nanoparticles that exist in perinatal tissue. So for protein concentration, we have found over 300 different cytokines, chemokines, and growth factor. And these are signaling molecules that act on pathways that affect tissues and immune cells. So every single one of these proteins has a cascade that it will target and it will control something. And our release criteria or our concentration is around 1.8 milligrams per ml. So to put it in simpler words, what are these crazy looking names of cytokines, chemokines, and growth factors that you see in the bottom? What do they do? And I've classified them here on the right side. So they are pro-angiogenic. Angiogenesis means that it creates more vessels in a tissue. And when you have an area that is not correctly perfused, that there's no enough vessels, there's no oxygen, and there's no nutrients getting to that area. So being pro-angiogenic is very, very helpful for what we're trying to do, which is regenerate in that area, right? Anti-inflammatory, immune modulatory, meaning that it targets the immune system in a way that it activates who has to be activated, and it calms down the ones that are overreacting. Tissue repair and pro-metabolic. And I'm talking, these are only the protein side of this product. Also hyaluronic acid. Hyaluronic acid is it's a matrix, how do I say it? It provides cushioning. Hyaluronic acid is one of the ingredients that has been used lately in orthopedics. Very successful. Aesthetic applications are being used all around the world. So this is one of the components as well in our product. But what I want to focus in, and what our big research is really going through, is these extracellular vesicles or exosomes, and these nanoparticles that actually we think are containing what makes our product work really good. So exosomes, we thought before that exosomes were the release of garbage from the cell. So the entire scientific community thought they were just, the cell was just secreting garbage, because we did not have the ability to actually see what's inside of those bubbles. So there are lipid bubbles, but if you don't have the ability to see inside of them, then just classify it as garbage being secreted because we were able to see them. So now 2021, and it's been, I would say, in the past 8 years that it became super strong, the way that we can actually analyze what's inside of them, that we've been able to classify them. So exosomes are extracellular vesicles that have an endosomal origin. So they come from inside the cell and they're secreted to outside of the cell. They are released by many different cell types and participate in various physiological and or pathological processes. It depends on what information the cell is carrying, that information that it's going to release outside and communicate with other cells. Exosomes works as information messengers to other recipient cells. And depending on the origin and information transfer, they can alter the fate of the recipient cells. That is so important because what they are carrying is an information that can be so precise that can actually change the fate of that cell that's receiving the message. For them to be classified as exosomes, they have to be 40 to 200 nanometers. So that is extremely, extremely little. This is another graph that more or less just lets you understand how we have cellular proteins like messenger RNA, microRNA, other proteins and enzymes. And in this year, we've learned about messenger RNA. Vaccine was recently approved with this type of technology of a messenger RNA. Their vaccine is very specific of just copying the spike of the S protein, right? And this is happening in every single cell of ours right now. The body and the cell just gathers around the information, puts us inside of this big bubble, and I'm going to just call it like that, creates smaller little bubbles, lipid bubbles, and then brings it to the membrane so it can be released. And inside of these exosomes, that's what's going to be contained. Messenger RNA, microRNA, and free-flowing either proteins or enzymes. So they can go to near cells, or they can really travel really far away. Once they release the information, that cell will just release those messenger RNA, microRNA, enzymes, and proteins. So it is very fascinating, the world of extracellular vesicles and the future that this type of technology carries. So for this exosome, we do a quantification through a nanosite, and we see how many of them there are. Our average is between 200 to 400 billion exosomes per ml. And with a Riley's criteria of 0.5 times 10 to the 11. And remember, I told you it is really important to it's important to know that for them to be considered exosomes, at least in the size, they have to be a certain size. So ours, we are under the 100 nanometers. So those are classified as exosomes. And here's a little video of how, when we do the measurement of this nanosite, looks like. So it's very, very advanced how it picks up the light reflectance of these particles that are moving, and then creates a chart, as I showed you here, of as many runs as you go, it averages, and this is what we get to see. So it's a very advanced technology, what we're seeing. I also brought you a case study. Let me just stop right there. And so for the past 5 years, we've been gathering information about this perinatal derived extracellular vesicles, proteins, and understanding what this placental tissue, perinatal tissue carries in the regenerative components. And we've been working strategically with lung injury in one side, and as I mentioned, osteoarthritis on the knees on the other side. But last year, we completed, not last year, oh my God, I'm sorry, 2019, we completed all of our preclinical data on bronchopulmonary dysplasia, which is a lung injury that happens in babies that are born too early. So understanding how our product can actually impact these lungs that have been exposed to oxygen when the lungs were not ready to be exposed to oxygen. We were ready to move into our application for FDA for COPD. And COPD is a chronic obstructive pulmonary disease where at the end of the day, the lung tissue gets injured and pretty much dies, or it doesn't work anymore, because the lung tissue, what it does is exchange our gases, right? But when you get older and after overusing the capacity of your lungs, the lungs stop working. And that's what we were focusing on, and our models were focusing on, and COVID happened. So when COVID happened, and understanding that patients go through an injury, an acute injury by this infection that kind of mimics this problem in the lungs, we were able to present all of our preclinical data and everything that we've been working for to FDA, and ask for the opportunity to actually investigate our drug in this scenario. So we were one of the first ones that made that application. And when I say us, in the space of the perinatal tissue derived exosomes, and in less than 30 days, we got granted and accepted our application for investigation. So as soon as that happened, we also were able to treat several patients that were infected with COVID, but in different scenarios. So we've treated the patients that had mild to moderate, meaning the ones that were just infected, the ones that were moderate to severe, also the ones that were in ICU for over 40 days, and the ones that got infected, did not have the infection anymore, but had been carrying a lot of different symptoms that were caused by the infection. So those are now called the long haulers, or the post sequelae of COVID. And so we are carrying along not only one but two of the trials specifically for COVID. And I brought this case study just to show you one of the patients. Actually, on Thursday, we got our publication accepted. So pretty soon it will be out with everybody, with the public, so you can read about this specific case study in the literature. So as I mentioned, this is an emergency use. Emergency use trials are just a single patient trial. And we do understand that to make scientific sense, we have to have those double-blinded, placebo-controlled, randomized, multi-center trials, which are ongoing right now. But nevertheless, I just wanted to present this one. So it's a 55-year-old male, 79.5 kilograms. This patient was hospitalized for 7 weeks due to mild to moderate acute respiratory distress syndrome due to COVID-19. During this hospitalization, he was admitted twice to the ICU, was never intubated. And then he was discharged from the hospital, but he was physically, oh, I apologize. Well, when you live in the mountains, there's a bear outside and your dog goes crazy. So at the time of discharge, the patient was physically limited due to the deconditioning and having shortness of breath while performing limited activities and daily living. So meaning he was not able to eat his meals because he had shortness of breath. He could not walk from the bed to the shower or take a shower. And he even referred like brushing his teeth was debilitating. He couldn't sleep in a flat position because he could not breathe. He was like elevated to sleep. And chest x-ray images revealed a bilateral pneumonia at baseline being before we treated him, right? But he was already discharged from the hospital. And this is a reality that we believe in Organocell is the next pandemic that we're going to face in healthcare, is this long haulers or the ones that are carrying a long sequelae after COVID infection. So what do we have to do is every single trial has to follow a specific order, and there's a schedule of events that happen, and I've summarized them here. So we had to know that the patient indeed at one point was confirmed COVID-19 positive. They have to sign their informed consent, collect demographics, medical history, physical exam. We do chest x-ray or CT scan and laboratory testings. And for us, the most important thing that we have been analyzing are these biomarkers that tell us how much inflammation there is in the body overall, right? IL-6, TNF-alpha, D-dimer, CRP, CBC, just to know where the metabolic panel is. And these are taken in days 0, which is, as I say, baseline, 4, 8, 12, 21, 28. And we treat with our drug the first day 0, 4, and 8. So they receive 3 doses. And we actively look for adverse events and infusion-associated adverse events within the first 24 hours after infusion. So this is something that gets monitored not only by the physician, the nurse, but the team that's overlooking the trial. And then there's an IRB committee, which is like an ethical medical committee that oversees the trial and approves you to do the trial, and FDA that approves this trial. So it is a very large group of people making sure that when we're testing a new drug, this drug, first of all, is safe. And this is the first thing that we try to do is just safety. It's the most important thing. But as we do include many of these metabolic panels and images, just to see how the patient progresses, right? And just to summarize, on the day of the treatment, the patient O2 saturation remained at 96. By day 8, before we administered the 3rd dose, the patient reported no signs of fatigue and shortness of breath. O2 saturation improved to 97 to 98 after that first dose. And after our chest x-ray at 28 days revealed no evidence of any more pulmonary abnormalities. The patient was able to return back to work in the OR, and after 1 month of initiation the protocol, this was a physician that was working on the front lines of the pandemic. So he was able to, at 28 days or let's say a month, go back to work and be back to being a surgeon. So again, this is one case report, and we are working really hard to move through our double-blinded placebo-controlled randomized trials. And you'll be hearing from us a lot because there's a lot of publications that are going in. And I always like to leave this quote, because this year especially has showed us that even in the most difficult times, who's working behind the scenes, the medical and scientific teams are working really hard. So don't give up. Science will show up. And we've seen it so far that sometimes we feel like nothing's happening, but there's a lot of us working really hard in the backgrounds to try to make a difference. So thank you so much. Thank you for listening. I know there must be a lot of questions, and I'm always available to answer those. I leave you our company website and also my handle. I'm simple around all social media, Maria Mitrani.
Thank you so much, Dr. Mitrani. We truly enjoyed today's informative session. We will now begin our Q&A session.
Thank you very much for that incredibly informative session, Dr. Mitrani. My name is Hamza, and I'm attending a joint BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine in Pennsylvania. To start off our Q&A, is there a residency for regenerative medicine? If so, did you complete the residency in regenerative medicine?
When I 15 years ago, there was no specific residency for regenerative medicine. I don't think there's one that I am aware of right now that you would just finish your MD and then go to residence for that, because still regenerative medicine, cellular medicine is just so diverse. You can, as I mentioned, you can just focus on the autologous side, or you can focus on the perinatal side. But if you do the perinatal side, you can focus on so many different tissues of it. So not that I'm aware of right now. You definitely, there as cell biology, that there are programs right now. So, but that is more focused on the lab work, right? But as a physician, I have not heard, and if you hear, please let me know, because I would love to point it that way, because that is one of the biggest questions there is. It's still a field. This is a very, very new field.
Speaking of this field being new, what made you pursue regenerative medicine specifically?
So as I mentioned before, my parents have been practicing for over 45 years in preventative and regenerative medicine with different approaches. Obviously, back then, they did not have any cell therapy. And when that was presented to us, I mean, that was cutting edge research that we wanted to bring it to the clinic. And we were really able to do so in Ecuador. And launched a beautiful project there. So for me as a physician, I want to see this therapy in the clinic ASAP. I really want to see that transition into the patients as soon as possible, because there's so many conditions that are just in a limbo right now in the medical field. So for me, that was the most important thing, to be able to get it in patients. And obviously, going through all of the regulations and rules, we are following every single path that needs to be followed.
I think a common question a lot of people would have is, where do stem cells come from? Can you explain that to us?
Yes, of course. And going back to that little chart of autologous and allogeneic. So we all are born with stem cells. So that is, I think, one of the things that most people don't know is that us as adults right now, we have stem cells. As newborns, we have stem cells. There are stem cells in the perinatal tissue. And the mother of all stem cells is when the egg meets the sperm. That first cell that's created is the mother stem cell, because it will keep dividing and create a new human, right? So throughout the way, and even we can die with millions of stem cells. So in the adult, just going to the autologous, us right now, that we have stem cells are regenerated actively, cells, organs, and tissues in your body, but they're dormant and kept dormant in these niches, and specifically the niches that are collecting a vast majority of the stem cells are in the bone marrow and in the adipose tissue. So depending on which stem cell you want to focus or work with is the ones that you will be collecting. But because they are, as I said, dormant, it's like they're chemically sleeping. And some of them get released to the blood, and they circulate and they do that minimal amount of repair. But we can actually die with millions of those stem cells that could have helped us. But that ticking clock that goes through life does not allow that to happen. So that is in the autologous. And then the allogeneic is the ones that are donated. So it can be donated from an adult. There's a lot of companies out there working with bone marrow stem cells that they cultivate, expand those cells and work with those cells. So an adult donor donates to an adult, or the field that we are working is the perinatal derived tissue cells, and you expand those cells. And one step further is collecting those exosomes, right? Our main product does not contain any stem cells or has not manipulated cells. We have not expand those cells, but we're more focusing on the proteins, exosomes, and hyaluronic acid that comes from that full-term perinatal tissue. So hopefully that answers the question.
I think that does. We still have quite a few questions about stem cells, though.
Yes, please.
Yeah. What is the difference between adult and embryonic stem cells, and which is preferred for research and treatment potential?
Yes. So, and this is the journey that I embarked for so many years, is understanding the potency of the cells. So embryonic is the early stage, as I mentioned, just those. As soon as the baby is formed, not only the mother cell, but the other divisions are very, very regenerative. Those cells will eventually make organs, tissues, right? So those are the most primitive stem cells and can actually either create a new human or create big time organs and tissues, right? Then it goes down the line to when the baby is born. Those are very regenerative, but those cells will not redo a new baby, right? A new human, but they can actually do tissues, right? And the adult ones are the less regenerative, but still very regenerative because they are circulating in your blood every day to regenerate your day-to-day wear and tear. So which ones are better is, I think, the question that all of us have. In the US, we are not using any embryonic, the early stage cells. I don't think around the world nobody's really focusing on embryonic. Everybody that is working with stem cells is working with the full term pregnancy perinatal tissue, and then expanding, and then adult. Those are the two big focuses on research and medical treatments right now. And which one is better? I don't know, because we are such in an early stage. And I really think that there's a space and a place for every single therapy that's being discovered. So all of you might be the next generation that actually gives us that answer.
Thank you very much for that answer. You just told us, there's a lot of people, a lot of countries that don't use embryonic stem cells. Can you talk to us about some of the controversies and ethical implications surrounding the use of these embryonic stem cells?
Yes. So, and this is the reason why in the US they were totally banned for a big, almost a decade. The work with stem cells happened because IVF started, is when you are, hopefully everybody understands IVF. Yes?
Yes.
No? Okay, thank you.
Can explain it just to be safe, but
okay, when you are trying to conceive a baby, but you cannot do it yourself, so you go to the doctor, and the doctor collects eggs and collects the sperm, so they bring it to the laboratory and make the babies outside of yourself. And once the egg has grown into let's say 7 days, just to give you a number. I am not a fertility expert, so I'm going to let that for the fertility experts. But when the egg is ready to be implanted in the uterus, then they will bring you in and inject those babies. So usually they collect, let's just for sake of numbers, collect 20 to 30 of those eggs. They're ready for mom and dad. They come in the first session. They never put only one, because that's how this field is so advanced. They know that at least they have to put several of them, because not all of them will attach. So they go through this session. They see if the baby attached or not. If one attached, if none of them attach, they'll have to repeat the whole course again. And in a matter of times, usually you have twins or triplets, right? And those babies that were fertilized, that were ready, if we started with 30 and you go through 2, 3, 4 sessions, right? And you eventually have and carry on with a pregnancy. Now you have triplets. After 2, 3 years, you say, okay, I still have my babies. I want others. I want more babies. So they try again this session. And what happens is, at the end of the day, not everybody will use all of those fertilized eggs. And in 5 years, those eggs are not viable anymore. Just because the time that they've been sitting in that stage, frozen, won't carry a perfect pregnancy. And that is, again, one more time, I'm not a fertility expert. I'm just giving the overall. But at the end of the day, it's a time where the physician calls the mom and dad and says, you know what, we have to discard these babies. And I would say 15, 18 years ago, they said, well, instead of discarding, can we donate it to science? So these were potential babies, potential human beings that, if they were to be put in a perfect environment, they would thrive and create human beings. And those were donated to science. So a big ethical and science, medical, and the public, religion, everybody had something to say. And it became a big dilemma, because who are scientists and doctors playing as God, as playing as, okay, I'm going to experiment on this potential human beings. So the stigma over stem cells was created then on the embryonic stem cells that were studied from such an early primitive stage that would actually potentially had been a human being, right? So that is the cloud that we still face today, because usually people, when you say stem cells, they either think, oh, that's super cool, or you're killing babies. But it's that brought the stigma to the field. And I am super proud to say the rest of the field kept advancing and moved away from the embryonic cells that will potentially create a human being, and collected other very regenerative cells. And we have moved on. The entire world has moved on into other fields of stem cells.
All right, thank you. Now we have a lot more questions specifically about the medicine of stem cells. So what does the future look like for stem cell and regenerative medicine research?
Wow, I think it looks very good. I think more and more people are making big leaps in the research and investigation of different conditions. But again, you can name a gazillion diseases, and their application need research. So I think there is going to be different types of stem cell therapies directed to different types of diseases. And it's just a matter of time and research that will give us those answers. For our own sake, from our company, we decided to focus on the non-cellular component of regenerative medicine. So we can create a product that can be mass produced, so we can go to the masses and create these clinical research trials that can eventually have a drug designation.
Thank you for that. Do you believe it's possible to reduce the need for organ donors through stem cells?
I think that is a very futuristic question. We're nowhere there right now. I think there's a lot of programs that are working on this type of just creating organs. There's so much that you see out in the literature that noses, ears are created, pancreas, kidneys are created, but to put those isolated research programs into actually a mass production, nothing like that has happened yet. But that doesn't mean that you guys as the next generation can surprise us all, because we have many people that are healthy if it was not for that organ that they are desperately waiting for a match. And if we can make a match out of stem cells, or the patient's own stem cells, or a type of stem cell that is not going to unmatch, that will be phenomenal. So there's a seed.
All right, the next question we have is, can stem cell research be used to reverse the damage done by cancer?
Can you repeat that? Can stem cell
research be used to reverse the damage done by cancer?
Well, there is a lot of companies that are really focusing on cancer. So, and it comes to my mind, one exosome company. So to mass produce exosomes in the field, you gotta mass produce stem cells and then collect the exosomes that come after from a specific cell line. And there's a company that is working already phase 1-2 in the US and the UK for that specifically for cancer. But again, there's cancer of every single cell type in the human body. So then we will need research for every single type of cancer. So it's a very broad question, but there are trials already working on cancer.
This is the opposite question. Can stem cells themselves cause cancer?
If they are collected for a very early stage, they have shown, embryonic stem cells have shown to be teratogenic. So yes, there you have to be very careful which type of cell you're working with, so you know what the outcome is, right? And that's why I think the entire scientific community has moved out of these early primitive stages, and move more into the more mature cell lines to work with. So definitely, I think the field is very knowledgeable right now on which ones you can safely work with, which ones not.
All right. Now this goes back to that thing about isolated research making, organs. How are humans able to manipulate these stem cells to make these organs in the first place, like the nose, the kidney, the ear, etc.?
I am not a specialist in that, so I don't know.
All right, that's okay. Do you believe that stem cells can possibly in the future reverse some negative effects of aging? Because aging is, of course, the degradation of DNA over a long period of time.
Yes, and apologize, but I gotta clear the throat.
Okay.
I think the field is very focused on this. We all really want to stop aging, but to scientifically prove it and to come up with a protocol that FDA will like it, that's where most of us are hesitant on going into this. But yeah, definitely, that is definitely one of the fields that we all want to jump in.
What is the latest development in the legislation for embryonic stem cell research?
So in embryonic, there's here in the US specifically talking, because there's other countries that will be listening to this, but here in the US, there's nobody working on embryonic stem cells. Not that I know. I'm going to say it. There can be any laboratories that are working with that under specific approved trials. But as I'm saying, most of the field that is working and has approved protocols are working with not the immature that can potentially become a baby kind of cells, are the ones that are more mature and that just can create organs and tissues.
And I think this is going to be our final question relating to stem cells, like in depth, which is, has therapeutic cloning or somatic cell nuclear transfer in humans been successful, as it has been successful in a number of other animal species?
Okay, you gotta bring that one again. Has
therapeutic cloning or somatic
Oh,
cell nuclear transfer in humans been
cloning.
successful, like has been for other animal species?
I don't know about that.
Right.
This is a very, very specific question. I know there's animals, models that have been clonated, but cloning is not my field and my specialty, and I don't know any human trials that have been done. Like in big studies, no. That will be revolutionary, and I think we all would be aware of it. In the US, let me put it that way. I know that China has a big community of scientists working with embryonic cells. So that is again different rules and regulations. And I don't know other countries, but I know about the US.
All right. Thank you very much for these questions. I'm going to allow Zaid to take over for the next few questions.
Thank you, Hamza. My name is Zaid, and I'm an undergraduate student from California. So for our next question, it's regarding the Zofin. So as you mentioned, Zofin can be used for application in treating patients with COVID-19 through your case study. What are the current results looking like in phases 1 and 2 for using Zofin in emergency use at a larger scale?
Yeah, so we are moving along, and right now asking for the next step, which will be a phase 2. Still waiting for FDA to evaluate those results. Actually submitted a paper Friday with all the results of EA. And we are, going through these phases. I wish it could be faster so we can all have answers, but we are not Pfizer or Moderna that have the logistic to just move this fast. So we are going as fast as we can physically can, but moving along, moving very strong to get this phase 2 going and being able to implement this into a bigger population, collect that data, analyze that data, present that data, ask for phase 3, and keep going. So
Thank you. And how are the clinical trials going for Zofin? On what scale are they being performed?
Well, so on our website, you can see the progress of our biologic pipeline. All of them are in phase 1, 2. And we are about to launch our long hauler trial. And we've taken a little pause for the COPD and osteoarthritis of the knee, just because the world's focus right now is in COVID. So we're really trying to nail down the COVID trials that we have approved right now and getting them going before we start the other trials.
Thank you. Another question we had is, what is the latest development on the legislation for embryonic stem cell research?
Yeah, so Hamza actually asked that, and I know that embryonics are really not considered right now, unless, again, it's a specific university kind of research that will not transition into humans. It's very clear nobody wants anybody playing with such primitive lines of cells.
Thank you. What have been some of the innovative breakthroughs from OrganiCell besides Zofin?
Well, I think Zofin is the biggest thing. The breakthrough is definitely working with the cell-derived messengers instead of the cells themselves, because once the stem cell, if you work with stem cells and you put the stem cell into your patient, it's actually those stem cell messengers or exosomes that get released what will trigger the information to happen. So the biggest thing that organocell has done is really bring into clinical applications the usage of only the messengers and proteins instead of using the cells. So um, that I think is the biggest thing we've done.
Thank you. And how do new pharmaceuticals like Zofin and other innovations get FDA approved after the stages that they're currently in?
Well, that is really, really hard work. And I am very fortunate to say that my regulatory team, my scientific team, it's so knowledgeable and has worked for many years. And exactly this, requesting application approval from FDA. So they've been navigating with FDA for over 25 years in their other jobs. And we were able to have them as our team members. And the reason why in the industry, we were one of the first ones to have in less than 30 days an approval for COVID. So just to give you a visual, what you present to FDA is a book of around 400 pages with your rationale in absolutely everything that they ask you for. So, and once you present that, they take 30 days to analyze. They come back. There's 3 different teams in FDA, one that just managed clinical, that one that managed like the chemistry part of it, and the other one, I'm forgetting one. Anyway, so those 3 teams are divided and analyze your 400 pages, and they come back to you with questions. And it's up to you to answer those questions in a very short, timely manner. And they can be questions that put a clinical hold on your application. And when you have a clinical hold, that means that you can not go ahead until you actually answer this clinical hold questions or CMC hold questions. So they go from questions that are simple to answer, questions that require new research to be developed in your preclinical, and so you go back and do the research and present what they ask, or they're actual questions that you can be like, if you don't have the ability to answer those, then you will be on a hold. And that's what a lot of companies happen to live on a hold until they figure out how to answer. So it is extremely tenacious, and it requires a very qualified team to get through this.
Thank you. And looking more into the future, beyond FDA approval, what's the next step to this treatment being used more universally once it is approved?
Yeah, I mean, that is the goal, right? Usually it was taking the field, let's say 5 to 8 years to get an approval from FDA. There's not many cell-derived therapies that have an approval. Mesoblast have been one of the biggest ones that was ready for approval, and then FDA came back and said, no, we have more questions, and so there's a hold on that. So but COVID actually made a big difference this year, meaning that in less than a year, we have an approved biologic from messenger RNA type of vaccine. And that just means that there were enough people treated with enough safety and efficacy that could be monitored and showed and proved that they could move from phase 1 to 3 in such a short amount of time, that they treated more and more patients than ever before for a drug to be approved. So that means that it's just a matter of doing a bigger population and showing and proving that you can be safe and efficacious to get that approval. So our goal is moving 100% to a drug approval. to then it going to market. So that is our goal. We won't stop until we get it.
Thank you. And moving to our last few questions of today's session, how do you manage the funding for your company?
So we're a public company. So that is the best way that we envisioned many years ago. The only way and the only pathway for us to be able to have this dream come true is to, even though everything that we did throughout many years was just putting it back into the same company and feeding the same company to a point where we went public, and we're still working on that. But being public is has been the way that we are going to this phase 1 and 2. Mm-hmm.
Thank you. And how do you stay up to date on the most recent treatments? Like, for example, you mentioned the mRNA vaccines for COVID.
Well, in this field is up to you. And I think in every field, it's really up to you on trying to, there's data produced and papers produced like crazy. And there's so many journals out there. So if you focus on what your field is and pick a couple of journals that are more focused on what you're specifically doing, because at the end of the day, everybody ends up focusing on one thing. So if you can be on top of that and become an expert on that, then that is the way to be on top of it, right? For us, that is where we're trying to publish, where we are really attending all their meets. And it's a job that never ends. So even when you go through med school and you graduate med school and then go through residency and you're finally an attendee, medicine never stops amusing us. So you have to be on top of your publications to always be relevant. You can't just rely on what you learned 10, 15 years ago, 20 years ago, and keep doing that way, because every day there's new things coming out.
Thank you. And for our last question of the session, how do you manage your work-life balance?
Well, you know what? I'm so happy that you asked that question, because yesterday I was traveling and I was able to watch this documentary called Do Not Harm. Is a documentary on physician and medical school students burnout and their rates on suicide. And it was so devastating to know that our field has the most amount of suicides, and that females are more susceptible to it, and that we're not talking about it. And that because how the system is set up, that thinking that whatever you do, you can end up, after all the money that you're spending, all the time that you're dedicated, you can be flagged and then not match into residency. And if you don't match into residency, there'll be the end of the world. That a human being can actually put in such a position where you will decide to take your life instead of facing the nasty reality that's given to us. So I hope this really resonates with all of you. Your life is more important than anything. There always will be a field where if you have passion to pursue helping humans, you will always find a place and a time. And going through med school is extremely hard because it really takes more than you ever thought it will. But it is so rewarding once you start working with patients, once you start working with your teammates, working as a healthcare team to navigate through patients' experiences. You get to see humans in their real stage. There's no masks when humans have a problem and they come to you for a solution, and that you generally want to try to help them. So always looking for your health, your mental health, knowing that if you feel you've maxed out, you go for a walk. If you feel you're maxed out, you go or a yoga session, cycling, dancing, making time for yourself, even if it's taking away 1 year from studying, taking away 1 year from residency, and just calling it your mental year. It's totally okay, because at the end of the day, you will be around for many, many years. So, last week, there was a beautiful summit called Ending Physician Burnout. And it was so incredible to see how many topics we discussed about the abuse that we go through in med school and residency, as females, as the minority groups that go through, and still we have to still push through, and we still have to go through. But there's new ways and new, I would say, leaders that we will take upon on overseeing that this exploitation does not go any further, that we are verbal about it. So thank you for that question, because I was going to somehow bring it in, but yeah.
Thank you so much for your time, Doctor. Those are all of our questions for today's session.
Thank you, Said.
Thank you very much, Dr. Mitrani. We truly appreciated that how you take the time to answer our questions. This was a greatly informative learning session for all of us. I'd love everyone to please give a warm thank you to Dr. Mitrani in the chat box for this incredibly informative session.
No, thank you, Amma. And thank you for your time. I know it's Sunday. It's very early here. And pursue your dream. I think we need more people. We need more females. We need more people from different backgrounds. Representation matters. And it's time to let your light shine. So all of the best on whatever you decide to do.
Thank you so much, Dr. Mitrani. Now we're going to conduct our closing session with our quiz and our future session dates.
Okay, bye-bye.
So the link to the quiz for the session is now live. And again, you'll need a 70% or higher to pass and receive certification. And I believe the link to the quiz was just sent in the chat. Don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox, and you can join from the link in the chat now. Now we're going to move on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday on September 4th at 10 a.m. Eastern Standard Time with our physician mentoring us in rheumatology. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.